Hello, and welcome to my clinical case presentation on vitamin B12 deficiency anemia. My name is Bonnie Moon, and this is for NURU 672, Management of Common Problems in Family Across the Lifespan Care at Bradman University. First, I will be giving an overview of the health problem vitamin B12 deficiency anemia. Other common names you might see are pernicious anemia and cobalamin deficiency. Pernicious means having a harmful effect, especially in a gradual or subtle way. And cobalamin is the name for vitamin B12. They refer to a condition where the body cannot make enough red blood cells because of the lack of the precious vitamin B12. Under microscopy, the red blood cells appear macrocytic. The erythrocytes are larger than normal with a mean cell volume of more than 100 femtoliters. Megaloblastic refers to the immature red blood cells that the bone marrow makes that are large and structurally abnormal. People can acquire vitamin B12 deficiency anemia due to an array of different malabsorptive and metabolic insufficiency etiologies. Decreased ileal absorption, decreased intrinsic factor, inadequate dietary intake, autoimmune disorder like thyroid disease and vitiligo, drug-induced, pancreatic insufficiency, breastfed infants with mothers malnourished or B12 anemia, and genetic transcobalamin 2 deficiency. Majority of people who have pernicious anemia can't absorb enough vitamin B12 from food. This is because they lack intrinsic factor, a protein made in the stomach, and it leads to vitamin B12 deficiency. With both cobalamin and folate deficiencies, thymidine synthase function is altered, and it leads to megaloblastic changes in all rapidly dividing cells because DNA synthesis is diminished. In immature erythroid cells, macrocytosis and ineffective erythropoiesis occur. Pernicious anemia is an autoimmune disorder with a genetic predisposition in 90% of patients. With human leukocyte antigen HLA types A2, A3, and B7, and type A blood group, antiparietal cell antibodies can result. Autoimmune diseases, including thyroid disorders, type 1 diabetes mellitus, ulcerative colitis, Addison's disease, infertility, and acquired agammaglobulinemia are associated with pernicious anemia. When taking a history of your patients, it is important to know that the incidence of vitamin B12 deficiency anemia increases in older adults, especially 60 years and older. There is equal incidence in women and men. There is a higher incidence in vegans and vegetarians due to the lack of B12 in plant-based diets. And there is an increased incidence in underdeveloped countries. It is also important to look for risk factors when taking a history exam, including inadequate vitamin D intake, as seen with alcoholics and strict vegetarians, GI surgery, including weight loss surgeries and resections, tapeworm infestation, malabsorption syndromes such as Sprue, Zollinger-Ellison syndrome, atrophic gastritis, post-gastrectomy syndromes, medications, for example, metformin, histamine H2 blockers, oral contraceptives, hormone replacement therapy, and proton pump inhibitors, and with chronic disease, such as Crohn's disease. When performing a physical exam, it is important to look out for these assessment findings because a vitamin B12 deficiency diagnosis starts with a healthcare provider's index of suspicion. You might see cognitive impairment, paranoia hallucinations, easily fatigued with exertion, ataxia, irritability, weakness, spasticity, peripheral neuropathy and paresthesias, vertigo, spinal degeneration like bowel, urinary incontinence, and erectile dysfunction. Other findings can include glossitis, bleeding gums, mouth ulcers, depression, insomnia, dyspnea on exertion, jaundice, hyperpigmentation, vitiligo, diarrhea, pallor, tachycardia, fatigue, palpitations, infertility, and neural tube defects, developmental delay, and failure to thrive in neonates born with mothers who have a vitamin B12 deficiency. The diagnosis of choice is vitamin B12 deficiency anemia, or pernicious anemia, or cobalamin anemia. Differential diagnoses include alcoholism, due to its similar symptoms and reduction of B12, folic acid deficiency anemia, because of the pathophysiology is similar, other macrocytic anemias, other neurological disorders, since B12 is important for normal neurologic function. They share similar symptoms. Hepatic dysfunction, because B12 is stored in the liver, polypharmacy, Alzheimer's disease, and mental illness. The best way to diagnose is with a complete blood count, peripheral blood smear, and serum vitamin B12 levels. The CBC and smear will show a decreased reticulocyte count, or hematocrit. The mean corpuscle volume is more than 100 femtoliters. The hemoglobin may be normal or low. The platelets may be decreased. The white blood cells will be decreased, and hypersegmented neutrophils will be visualized. The serum B12 levels will be less than 150 picograms per milliliter. Low folate levels can be seen because it impairs B12 absorption. Methylmalonic acid and/or homocysteine can be elevated with low B12, and anti-intrinsic factor antibodies should be checked for autoimmune etiology. With megaloblastic anemia, there will be an increased mean corpuscle volume, increased mean corpuscle hemoglobin, and megaloblasts and hypersegmented neutrophils, and mean corpuscle volume and hemoglobin may be normal. There can be an increased LDH, serum gastrin levels should be checked, and an esophagogastroduodenoscopy can be performed, as well as enteroscopy and a bone marrow biopsy if the etiology is unclear. To treat vitamin B12 deficiency anemia, non-pharmacologic management includes increasing dietary intake of natural sources of B12, found in foods like fish, meats, peas and beans, fortified cereals and supplements, and other protein-rich foods. Education should be given on the lifelong nature of the treatment. Self-administration of vitamin B12 is helpful and is important to treat and manage the underlying causative factors. Pharmacologic management can be delivered via intramuscular, deep subcutaneous, intranasal, and oral routes. Injections of B12 are usually managed at 100 micrograms daily for 6 to 7 days. If there is improvement, inject every other day for 7 doses, then every 3 to 4 days for 2 to 3 weeks. Intranasal dosage of B12 is 500 micrograms in one nostril once per week. Oral management is achieved through 1,000 to 2,000 micrograms daily for 1 to 2 weeks, then maintain with a dose of 1,000 micrograms daily. It is important to educate your patients after initiation of a treatment plan. Advise your patient to follow up in 1 to 2 months to determine the response to treatment and recheck blood labs. Inform your patient that even if they do oral B12 administration, that monthly B12 injections are advised. Endoscopy is recommended every 5 years due to the threefold increase in gastric carcinoma. Let your patients know that the anemia is reversible, but the neurological problems associated may not be reversible if the symptoms are severe and lasted longer than 6 months. It is important to understand that lifelong therapy is necessary for most patients, but after the start of treatment, the red blood cells peak in 7 to 10 days, and the hematocrit increases after 1 week. Lastly, let your patients know that vitamin B12 deficiency has a slow progression and develops years after insufficient dietary intake because the daily body intake needs are small and because large amounts are stored in the body and the liver. The U.S. Preventative Services Task Force for the American Academy of Family Physicians has issued clinical practice guidelines for the screening of vitamin B12 deficiency in the elderly. Prevalence reports show that it is common in the elderly with ranges from 5 to over 20%. Significant deficiencies can cause health issues like hematological problems, neurological problems, including combined sclerosis of the spinal cord and paresthesias, psychiatric problems, including irritability and dementia, and possible cardiovascular conditions, including increased risk of myocardial infarction. Screening for vitamin B12 deficiency has implications for both primary and secondary prevention. Parietal cell antibodies may be tested for the patient, but these are not specific to pernicious anemia. The Schilling test has become less important due to advances in research because differentiating between oral versus parenteral supplementation is unnecessary. Oral and injectable forms of vitamin B12 are suitable forms of treatment for the elderly. Suggestions are made to diagnose and start treatments early to prevent the irreversible effects of the disease. Here are the references for this clinical case presentation on vitamin B12 deficiency anemia. Thank you for watching.